welcome you all for this third edition of LTSI Masterclass, and which is going to focus on critical aspects of liver transplantation, particularly disease donor donation, disease organ donation. So, disease donation is actually a backbone of any robust transplant program, which offers a lifeline to patients with end-stage liver disease. So, however, despite growing awareness, the availability of disease organ donation remains limited, and many patients continue to face long wait times and succumbs before receiving the transplant. Now, maximizing the potential of disease donation requires a multidisciplinary approach, particularly legal and ethical clarity, timely identification of the potential donor, optimized donor management, and well coordinated marketing behavior. And all these factors can effectively increase donation rates and improve our. Today, we have an outstanding panel of experts led by Dr. Sonu Astana, who will provide us valuable insights into particularly the legal and ethical framework, which in my mind is actually the most important thing in terms of propagating disease organ donation, which governs the donation, ensuring compliance and ethical integrity. Next important thing is going to be strategy for early organ donation and effective donor management to maximize organ viability, and then best practices in retrieval of organs from diseased donors, addressing technical, logistic, and clinical challenges. So this session is not only going to be uh, focused on expert presentations, but we'll also be discussing practical cases to allow us to engage in real-world scenarios. I would request all the participants to please post your questions in the chat box, and in between the talks and during the discussions, we'll address all those questions and share your experiences, because once you share your experiences, everyone can learn from your experiences and then make this session really interactive and enriching one. So I will now hand over to Dr. Sonu Asthana for the first class, and Dr. Charles will be moderating the further round of discussion.
Thank you so much, Dr. Abhideep, Dr. Charles, and the LTSI executive for this honor and this opportunity to discuss something that is so close and so relevant to us. I'd like to clear some sort of myths before we start, actually, because one of the myths is that deceased organ donation or deceased donor liver transplant in particular is rare in India. As per the data that is coming out of the NATO for last year, almost 1 in every 4 transplants done in India are actually done from deceased donors. 25% of the transplants are done through deceased donations. So actually, if you remove off the number of transplants that are done for non-Indian nationals, then perhaps the number is as high as 1 in 3. So clearly, we're not talking about something that is very unusual here. We're talking about deceased donation, but the challenge, of course, is that it is not geographically as well spread as living donation. So it's predominantly happens in the south and the west of the country. So my remit today is to talk about the legal aspects of organ donation, which I'll kind of go into in some detail. And with this remit, I will sort of move forward, and there will be an opportunity to ask questions as well. Is my screen visible?
Yes, Dr. Sonal here.
Okay. All right. So we'll be talking about our particular law, which is actually quite interesting. It has its own vagaries, etc. But all said and done, it is probably quite a good law for our current reality. And I'll try to address some burning questions that keep coming up again and again whenever we talk about the law. Okay, let's change that. So these are my current appointments. I do not have any competing interests. And of course, as this is everybody in this particular group knows, transplantation is different from pretty much every other field in medicine because it doesn't require one person, but it requires 2 people. It requires somebody who can donate an organ, either a living donor or somebody who donates after death. And of course, it requires a recipient. So it isn't a technical and a medical part, but actually an ethical sort of branch of medicine in that particular way. Because without the gift of organ donation, transplantation could not take forward. And clearly, although our numbers have picked up in India right now, we have quite a number of liver transplants being performed. Its number currently is close to 4,000 when it comes to liver, but the gap between the demand and supply is quite high. And while we look at all the NOTO data for which the data is available, we can see that there's been a rise in the total number of organs transplanted, but also a rise actually in the number of deceased organs being transplanted. So how did this all start? So of course, organ donation and transplantation is not new. The technology that was developing in the 80s led to a substantial improvement in health outcome for patients with liver failure. So to give a background, the first kidney transplant was done in 1954, and the first kidney transplant was attempted in India in 1965, just 11 years after the first one was done in the world. The first kidney transplant in India was done in 1971 in CMC Bangalore, which was very, very successful. So clearly, you had a lot of people who were established on dialysis who could potentially develop from benefit from organ donation. So, and organ donation efforts had started to some degree in SGPGI in the mid 80s as well, but that was without sort of any overarching law. So, of course, what was happening was very typical. There was a higher demand than supply, and there were a lot of unethical practices. Clearly, the concern that was faced in front of lawmakers at that time was how to separate out. One is set up established guidelines for who could donate after brain death. And the second thing was, of course, setting up checks and guardrails for who could potentially donate in a living donor scenario as well. So, of course, this is something that we just talked about. We do not really have a cupboard, so to speak, of organs that we can delve from. We need donors for that. And clearly, this is something that we were known for across the world, actually, rampant commercial organ trafficking. This picture is actually from Pakistan, but it was certainly true for certain parts of India, including Karnataka. The background for this was actually it was called coma de passe by the French, an irreversible coma. This study that came out from Harvard in 1968, which recognized that there was another form of death, the form of death that we understand where the heart stops, which is called cardiac death, which everybody learns as an intern. You go and you certify people, you do an ECG, make sure there's a flat line, and you make sure that the person is dead. But there is another form of death in which people who have had traumatic or irreversible brain injury lose all cerebral functions, who cannot maintain life in the absence of ventilation. So this kind of irreversible coma was defined as brain death, and even at the time when it was defined, they basically identified that these are patients who could potentially be organ donors, because clearly while the brain might have died or the brain might have necrosed or undergone irreversible changes, but in the presence of an intact circulatory system, all the organs were actually viable. So when we come to 1994, the three state governments in Goa, Maharashtra, and Himachal Pradesh requested the central government. The reason for this was, of course, because health is a state subject in India. So three states actually had to request the central government to pass uniform guidelines. Okay, and this was in accordance with Article 252, where the center can then pass laws on a state subject. So this was debated for 3 years. It was passed in 1994. And according to the law, each state actually had to individually accept all the provisions of the THOTA and then constitute the appropriate authority and form authorization committee. So the remit of this particular law was to take organs from living other than brainstem dead donors and use them in patients for therapeutic purposes. This has since undergone several modifications in 2009 and 11, most notably. The last notification was in 2011, and the Gazette was passed in 2014. So the first question that people ask is brain death defined only in THOTA, and does it exclude other forms of death? So do we need a more rational definition of death? Actually, this is quite well laid out in our law in the definitions, where brainstem death means a stage where all functions of the brainstem have permanently and irreversibly ceased to function. And a deceased person is someone in whom there is permanent disappearance of all evidence of life by reason of brain death or in cardiopulmonary sense. So actually, the law is fairly clear in its statement when it comes to whether brain death is actually death or not. So it can be, it is stated quite clearly. So brain death and its declaration was actually very well laid out in the law. So you need 4 doctors who are independent of the transplant team, nominated by the appropriate authority of the government of the state, who will do a certain set of clinical tests 6 hours apart. These doctors are very well prescribed. The only difference in the current law is that you do not necessarily need a neurologist or a neurosurgeon. You can actually work with an ICU doctor or a critical care doctor to actually certify brain death. These are two forms which all of us should be very, very clear with. And these are forms that need to be examined by everybody who actually will do any organ retrieval in their careers. First is the Form 10, which is certification of brain death. Make sure that the patient is actually being examined, which patient has been certified, and whether all the four medical doctors have actually signed 6 hours apart. And the second one is Form 8, which is the declaration for consent, where the person in lawful charge of the body. Please remember that it is not always the first degree relative. It can be anybody who has lawful possession of the body. In case of an unclaimed body, it could even be the medical superintendent of the hospital where the death has occurred, who can actually give consent. The important thing here is that we have to make sure that all the organs that are being retrieved are individually consented for here. So basically, all the organs have to be spelled out, and you cannot talk about only abdominal organs or thoracic organs. Each organ has to be spelled out. If it is not consented for, then it cannot be retrieved. Now, brain death we talked about. It has occurred in patients with less than Jesus, less than 3 to 15. And of course, there is a cessation of brainstem reflexes. Dr. Ajit is going to go into the details of testing, so I will not talk about this in any detail. Of course, it is important to have an etiology, and it's important to rule out any other causes of potential reversibility, such as hypothermia. So who should be tested? Only ventilator-dependent patients. They should have a known cause of death. Condition should be irreversible, and you have to look for examinations as well as exclude major confounders. Of course, the physicians have to agree. There are 2 examinations 6 hours apart, and each part has got physical parts and confirmatory parts. Okay. So clinical evaluation, again, neurological evaluation. This will be covered in the next sort of talk. Documentation. So what is the time of death? The time of death here is when the second brainstem death has been concluded. The time of death is when the arterial PCA2 has reached the target value of the apnea test. In patients whom the apnea test has not been completed, then it is the time when the ancillary test has been completed. So apart from the clinical tests, there are ancillary tests such as cerebral angiogram, EEG that are defined, but these are not necessary to declare death. Let's talk a little bit about the different aspects and the amendments of this particular law. Living donation, I'll talk very briefly about this. Essentially, you have known organ donors where the division has been divided into near relatives and other non-near relatives, and of course, unknown donors where there are altruistic donors and costly altruistic donors. It's important to understand that all of these donations are legal in the Indian law, provided they are being done out of love and affection and not because of any commercial interest. So you can have a purely altruistic donation, provided it is done if the commercial interest can be completely ruled out. So the law made it very simple for patients who are within the family, that is called near relatives, the definition of which was spouse, parents, mother or father, brother, sister, son, daughter, grandparents, and grandchildren. In this particular definition of near relatives, anybody who is within this thing can actually get a clearance from what is called the competent authority, which can actually be the director and the medical superintendent of the hospital, provided they are not part of the transplanting team. Their primary job is to make sure that the relationship is genuine, and secondly, there is no coercion or pressure on the donor. Again, it is important to understand that as per the way the law is written, there is no responsibility in the transplant team to prove this relationship or otherwise. When it comes to a non-near relative, then basically it is important that it is an authorization committee of the hospital, which can be constituted within the hospital if the hospital does more than 25 transplants a year, or it goes to the state authorization committee. And the primary role here is to make sure that the motive for living donors to donate is out of pure love, affiliation, and affection, not due to commercial interests. The power of the entire quota in the state rests with the appropriate authority, which is responsible not just for licensing hospitals, also to make sure that the registrations and everything actually is as per the law, and the appropriate authority has the rights of a civil courts. It can issue summons, subpoenas, It can issue orders to produce evidence, issue search warrants, etc. So if there is any case that is filed under the quota, it has to go under the appropriate authority. So nowadays, we have a lot of fly-by-night decisions that the police takes by itself. Those are illegal because the first line of investigation should always be through the appropriate authority. So what are the documents required? Again, very, very well laid out. For example, the forms that are required, again, very, very clearly laid out which forms need to be filled in. Now, who can sign and who is responsible? This is very important. This is an important chart. For example, near related related donor, it is the recipient and the donor. Again, for spousal donor, recipient and spouse. Again, recipient and donor in the other places. It is only for medical fitness that the RMP nephrologist or the surgeon signs. That is form number 4. So clearly here, the only onus for certification is on the clinical team is for medical fitness. What are the penalties imposed by the law? A fine of 20 lakhs and 10 years imprisonment. If the accused is a doctor, then the names are struck off the medical council register. And again, like I said, in the section 22 of the Act, no court can actually take up a case directly until a complaint is lodged by the appropriate authority. So the process of complaining is actually to the appropriate authority, not directly to a court. What are the limitations of the current law? It is a central law and a state subject. So there are, we can have almost another session on this, where the fallacies of having a central law and a state subject are. Because in India, which is the federal constitution, there are very specific state rights. States are also very, very possessive about their rights. So how do we actually ensure that there is a coordinated movement across the country? There's a lot of discussion on one country, one law, but the reality is that the way our constitution is written, it'll have to be one framework and then many laws that finish that framework. There probably should be a uniform declaration of death because that seems to come up again and again. And of course, there should be some way in ensuring that the population that is the most vulnerable, that is donors who are probably doing it out of money or patients who have no other recourse to transplantation, we have to try to avoid criminalizing them because as per the law, there are obviously huge penalties for people who actually choose to take this route. But clearly, there has to be a better way to avoid criminalization. And again, like I mentioned, we can declare the uniform declaration of death, define a process better, and try to make sure that vulnerable people are protected. Then again, just a few questions. I'm going to stop after this. Why can the center legislate on the state topic? Yes, it can. If Article 252 says that if the states, if multiple number of states, more than 3 states, ask the center, then the center can do that. In spousal relations, who can donate? Of course, you ideally should have been married for a long time. And of course, the authorization committee has to use the discretion judiciously and pragmatically. Can the authorization committee ask for any document? Yes. It has got fairly large powers of latitude to ask for any documents that it might need to satisfy itself for a relationship. Do out-of-state patients require an NOC? Clearly not after this judgment in 2012. Who bear the burden of proof? The burden of proof is actually on the applicants. This is something that keeps getting misinterpreted again and again. But of course, the authorization committee has to seek whatever information it needs in order to prove the relationship. But actually, the burden of proof, a burden of even incorrect documents is actually on the applicants. And this is something that is currently being tested in courts in several cases as well. How long can the authorization committee take? It says that within 4 weeks or not more than 6 months. This is again as per previous High Court rulings. With this, I'll stop and I'm happy to take any questions. Perhaps we can do questions at the end of all the talks, or shall we do them now?
Yeah. Thank you, Dr. Sonal, for that excellent talk overview of the legal aspects of organ donation in India. Shall we take the questions at the end? Can we go to the next talk?
I think we'll probably do them together at the end.
Okay. May I invite the next speaker, Dr. Ajit Kumar AK. He's the secretary of ISCCM, and he'll be talking to us on diagnosis of brain death, care of potential deceased organ donor, and counseling for organ donation. Over to you, Dr. Ajit.
So can you see my PPT? Can you see my PPT?
Yeah, we can see your PPT.
Yeah. So good evening, friends. So I would like to thank the Liver Transplant Society of India to give me an opportunity to talk on this topic. The diagnosis of brain death, the care of the deceased organ donor, and the counseling for the organ donation. So we have around 15 minutes. I would like to just browse through that. And I'm happy to take up any questions at the end of the thing. Not moving, sorry. Yeah. So today's discussion, the diagnosis of brain death prior to donation. So basically it's about donation, especially liver donation, but I'll be talking from the intensive care person's point of view. I'll be discussing about the diagnosis of brain death. And, because now, if, for example, in US, the 65% of the organ donation from the deceased people, that is from the patients who are having brain death. But around 35% of the cases from the deceased donor that is coming from, donation after circulated death or donation after cardiac death, which is a little bit new to me because I know that in India it's happening. I will be just briefly mentioning that. And finally, I'll be going through the care of the deceased organ donor, which is a very exhaustive topic, but still I'll go through that. And finally, about the family communication. And obviously, the brain death evaluation before you evaluate the brain death. So these things are very important. There is no dispute regarding that. You should have a clinical and preferably a neurological imaging. 100% I would like to say that in my practice, we'll go for a neurological image evidence when we should not have a subjective thing. We should have objective evidence. For acute CNS catastrophe has to be there. Exclusive medical condition confounding clinical assessment, we know that dyselectronemia, acid bile variances, endocrine disturbance, circulatory disturbance has to be ruled out. Absence of drug toxication or poisoning, including any sedative drug. For example, if you ask me, snake bite is one thing in a venoms, when we can closely mimic in a brain death. So we need to get adequate time for the patient to improve from the toxin before the patient wakes up, in the coming hours or whatever days. And obviously, the temperature is very, very important, which is many times, the unwary may ignore that. The temperature has to be more than 36 before you do any kind of a brainstem evaluation. And obviously, the BP has to be more than at least 60, preferably has to be there. And obviously, examination findings, I'm going to go into details on that. All of you know, patient has to be in coma. And you should have you should not be having any kind of a response, which is originated from the brain, basically in the form of seizures, cortical activity, decerebrate or decorticate posturing. And obviously, you should have an absent pupillary reflex, most of the time. Initially, maybe there could be some kind of sympathetic storm where, because of that, the pupils may be dilated, then they come into some kind of a mid position, around 4 millimeter, there should be the reflex dilatation cannot be there. An absent corneal reflex has to be there. And the dorsal movements, we also have oculocephalic reflexes. One word about dorsal is that you are not expected to do the dorsal if the patient is having a cervical spine injury. So these reflexes, you check it. And, I'm not going to details on that. You all know that, when the dorsal normal response will be I will be going to the opposite side. When it comes to the cold caloric response, you instill the ice thing, it will be going towards the same side, will be there. And, obviously absent jaw jack, absent gag reflex, and an absent cough, because this is one of the last reflex to go, usually in and after brain death. And obviously neonates, I don't have any experience on that. And finally, you confirm the brain death by, the apnea test. The apnea test is very important because this is the final confirmatory test of after all the other criteria of brain death has been met. And obviously, we need to again recheck and reconfirm, and we need to document that, patient is normothermic, at least at 36 degrees centigrade. The BP is more than 100. Eucapnia has to be there. Before you do that, you adjust the ventilator rate. You can see that the patient is having a PaCO2. Absence of hypoxia is a must only because you're going to disconnect the ventilator. Patient should not have an hypoxemia and the related disturbance and the related complication in the test. And euvolemic status are the prerequisites. And obviously, this test is not valid who is having a chronic CO2 retention. And in case of neuromuscular paralysis, high cervical spinal cord lesions, because what you're actually testing is that after confirming all the other tests, after doing that, you are confirming that patient is not taking any attempted breathing, even after the carbon dioxide is going up. That is what the test is proving. So maybe, as you said, the high cervical lesions and these, whatever I mentioned, patient won't be breathing, so there is no validity for the test. And obviously, as I already mentioned, the PCO2 more than 60 or 20 millimeter, getting the basal values and a final arterial pH of less than 7.28. That means body is unable to compensate. Even in chronic CO2 retainers, you diagnose if the patient is having a negative apnea test. And usually, once you do the test in adult, we need an observation period is mandatory. So as Dr. Sonal has mentioned, we repeat a test after around 6 hours. But in US, it depends on varying between the countries and varying between institutions. Up to 24 hours more is allowed in hypoxic ischemic encephalopathies. That's what I came to know. And the thing is that many people try to go for the ancillary tests. The thing is that one thing we all should know is that the ancillary tests are in fact inferior to the clinical test. So honestly, in my practice, we try to avoid these accelerated tests, unwanted accelerated tests as much as possible. And obviously, when you are unable to examine the cranial nerves, you cannot assess the pupil, cornea. Patients having a very traumatized face, brain. Obviously, you can't do all that. Neuromuscular paralysis is present, heavy sedation is there. When other confounders that you go for ancillary test. So ancillary tests are there when you're unable to do the apnea test. For example, sometimes when you do the apnea test, what can happen is that you're unable to conduct the apnea test. Basically, patient has significant desaturation in spite of the best precaution. Sometimes the patient can develop unwanted arrhythmias. Sometimes the patient will develop some unwanted hypotension, which is obviously this not, you won't be able to assess the brain. In those conditions, which I am unable to do that, and the mentioned, whatever the theoretical thing which I mentioned in the previous, this one, you go for ancillary test. One of the most best thing which can be do ideally with 4-well angiogram. That's very, this one, it's like a DSA. Only thing is that whenever you do the 4-vessel angiogram, you need to see that the BP is appropriate, because if the BP is falling, sometimes the flow may not be there. That is one loophole of this case. And obviously, the 4-vessel angiogram, the absence of, blood supply, beyond the internal carotid artery, beyond, the petrous temporal bone, or maybe the basilar artery, the beyond the vertebral artery, beyond the intradural area, that can confirm, brain death. And in this case, we need to be again aware that patient was undergone some kind of a EVD drains or some kind of a decompressive craniectomy, which can decrease the pressure inside the brain. You can have a false positive, there won't be any, there will be some flow can be there, which can be, false negative, brain death can be there, that's one thing. And obviously transcranial Doppler, which has got a sensitivity maybe around 70%, specificity is good. Again, the sensitivity will improve after 24 to 48 hours. CT angiogram is one thing which has been used. The absence of filling of the the opacification of the intracerebral internal cerebral vein, that is supposed to be one of the very sensitive internal cerebral vein, absence of filling. And again, it just got the sensitivity maybe around 75% and specificity maybe around 100%. And another innovation, I think people can just research the literature. It is something called HMPAO. It's a long name, 99 technician labeled hexamethyl propylene aminoxidine SPECT scan. This has been supposed to be for something which is evolving. Again, sensitivity can improve after 24 to 48 hours. It has got a superior sensitivity and specificity when compared to other scan. So practically speaking, at this point of time, many of us are using for the CT angiogram, or preferably a 4-vessel angiogram, which is this one. And EEG is very non-specific, because your EEG will be able to detect any activity only the cortical area, maybe the immediate subcortical, areas, if at all. Nothing related to the thalamus or the brainstem areas. So EEG, normal EEG is of no use. Basically, that's what I believe. And there is something called atropine test. You give an injection of atropine, a bolus of atropine, and you see there is more than 3% change in the heart rate. It is believed that the motor nucleus of the vagus nerve, that is in the caudal medulla. So what can happen is that when this is affected by the brain, when the brain death, the change in heart rate more than 3% will not be there after injection. But again, this test needs further evaluation in critical care settings to recommend that. This is a SPECT scan, whatever which I told you, the big name, the long name, it's very new to me as well, HMPA or technician scan. So what is happening is that there is no flow. You can see this kind of a bulb lighting, the lighted up, the skulls. You can see that what it shows. And obviously the brain death mimics, I'm not going to details of that. All aware of the locked-in syndrome, neuromuscular paralysis, Guillain-Barré syndrome. Hypothermia is one thing, even day-to-day practice, once in a while you see surgical patients, there is no, we have seen a couple of patients even in the surgical ICUs as well. And deadly intoxicating venoms, I already mentioned you, metabolic encephalopathy, again, academically, you need to rule out, there is no other reason. And, with all that, about the brain death, I just want to mention about, the donation after circulatory death. As I told you, in US, 30% donation is from the live donors and 70% is from the deceased donors. The brain death of the deceased donors, 65% of the cases, it is from the brain death, and 35% is from the donation after circulatory death. What I want to tell you is that brain death constitutes only 1% of the total deaths. That is one thing. And it's hardly 1%. And I don't think so, because we have a significant mismatch between, the demand supply of the organs. And I don't think so. The way will be to look for, purely dependent on brain death. That's what I'm not to convey you. So here mean, it's a kind of a controlled cardiac death is achieved in those kind of patients, these kind of, when a mechanically ventilated patient has to be there, and a Glasgow coma scale less than 5 without sedation, brain death examination is being considered. You give some kind of triggers to the, the brain organized brain death, the organ donation procurement organizations, and withdrawal of the rice powder is being considered. You get a trigger to them. All the system is ready, and do not resuscitate a comfort care being considered. The family is also thinking about palliative. These are the kind of patients you alert the system, and it is ready for a controlled death. So what's happening in controlled death is that you disconnect the patient for 60 to 90 minutes. You see that the patient heart has to stop, but you wait for after the disconnection. You may take around 60 to 90 minutes time will be there. And sometimes what can happen is that you after the death is confirmed, again you give around 2 to 5 minutes. Sometimes what can happen even after the confirmation of the death, the heart stoppage. Again, a very small percent of people, I don't know, it's very new to me as well. There is something called auto resuscitation, because they can again, some kind of auto resuscitation can happen, the heart can start beating. So again, you give, up to around 2 to 5 minutes. This is called this one, you do that, then you confirm that, and then you go ahead. If the patient is not passing away, if the patient is having, getting auto resuscitated, you will not proceed with, this, death of, the donation after after the cardiac death or circulatory death. So again, this is the triggers which I mentioned to you about, contraindicated for an even, the controlled death, whatever the donation after cardiac death. So any death, age more than 90 years, this is not an organ donor, ideally, but still there are case reports are even people with 90 to 99 also age also has donated organ. Patient is not on a ventilator, is never a candidate for donation. And history of active metastatic cancer, active metabolic malignancy, history of active melanoma, patient is having some sort of slow virus disease, Creutzfeldt-Jacobs disease. These are the conditions patient will not be there. In my practice, because I don't just depend on reading this is just to prime everybody about this. I will discuss with the experts. We discuss into the transplantee whether these patients are there or not. Then only we'll make it this one. But this is a general contraindication. And obviously, there are the different categories are about the controlled brain death or this one. I'm not going into details on that. And coming to the management of disaster, the deceased organ donor and his deceased organ donation is very, very important, because unless you manage the patient properly, there can be some kind of a unwanted, dysfunction can there in the transplant in the long term or the short term, number one. And if you manage the patient properly, what can happen is that you can have, better organ, multiple more organs can be successfully retrieved. So naturally, you do all the monitoring and access. I'm not going to read it everything. This is done in almost all the ICUs. You look at all the vital parameters. You monitor, all these parameters which is mentioned there. And obviously, the goals of resuscitation, obviously, it can be to many extent in normal body temperature. You see the euthermy. Euthermy is very, very important. That's very important, because even otherwise you can't do any kind of a test as well. That's the temperature is better to be euthermic or mild normothermia. Some people keep it around 34 to 36 after confirmation of the brain death. But before confirmation, it has to be more than 36. The mean arterial pressure is more than 60. It is varies in the literature between 60 to 110, but more than 60 is international accepted amount. CVP is less than 12 because the fluid overload, POP less than 12, and SVR, all these things. This is all from the textbooks. And obviously, maintain U-volume, that is very, very important. It has been believed that in kidney transplant, it is better to have a overhydrated patient, because that is supposed to have an excellent result. It is believed that. But for the other transplants, for example, lung, heart, pancreas and liver, it is believed that it is better to have a normally hydrated thing. It is not a thing. But studies have shown that that notion is not correct. Even for the kidney transplant, there is no need to overhydrate these kind of patients. That's the current thing which is evolving. But obviously, normally hydration is better. Overhydration, again, it can adversely affect other transplants of other organ, liver, heart, kidney, and liver, heart, liver, heart, lung, and pancreas, which I already mentioned to you. Electrolytes imbalance, it's very important, because what can happen is after the significant inflammatory response is going to happen in a patient, significant autonomic storms are this one. And you can have many patients developing diabetes insipidus. The sodium is just going to rocket around more than just going up. You need to see that it is between 135 to 155. Maintain the potassium between between 4 and 5. And many times when you have an arginine vasopressin deficiency patient with diabetes insipidus, you get a significant loss of this magnesium, calcium, phosphorus. We need to be there. And obviously, lactate and all, we need to closely monitor. And obviously, ventilator setting, you go for a 6 to cc of the predicted body weight. I'm happy to discuss that. And you give people around 5 centimeters. Obviously, give a FiO2 of 1.0 in the beginning. Obviously, once the oxygen is all right, you keep it between 0.4. And obviously, you are looking at an oxygenation about PO2 of more than 90. You titrate the SpO2. I mean, the FiO2 in such a way that saturation is more than 95%. And obviously, when you have an autonomic storm, initially, especially the initial time, what's happening, the denervation happening, there is a control of the CNS is lost. You can have, the sympathetic drive will be there, and the BP hypertension crisis can be there. Usually, it is believed that we usually go for metoprolol and very low dose metoprolol on this one, but the esmolol may be the better thing. It is very short acting and have a better control of the hypertension. And obviously, some of the blood anomalies, when it is more than 1.5, is the thing you give the blood products. Hemoglobin, we keep it more than 7 or 8 is more than all right. But some people go for a little bit higher value, 8 or more than 8, especially some of the surgeons who believe that, especially patients who already had abdominal surgery, they are going to open the tummy to get the organ out, but more bleeding is likely to happen. These kind of thing, they go for a higher hemoglobin sometimes, in clinical practice. And vasopressin inotrope, when you do the adequate volume resuscitation, then what's happening is that BP is still on the lower side. One thing which is happening in the transplant setting is that in most of the ICU setting, in general setting, we go for norepinephrine. In this setting, it has been advised is that let's go for vasopressin. Vasopressin is not only an inotrope. I mean, it is not only a vasopressor. It is just going to be useful for the control of the diabetes insipidus, which often happens with the brain death patients. And obviously, the MAP is less than 60 and heart is normal, then you can add other vasopressors. If the heart is poor cardiac function, you may have also some kind of dilators as well. I'm not going to details because of the time constraints. So in arginine vasopressin, the 0.1 to 0.01 to 0.4 units is there. You give, these hormones. The hormone therapy is extremely controversial. Some people believe that there is no need to give this kind of a hormonal therapy, whatever we have mentioned. I mentioned the PPT to all the patients. Only those patients who is having significant hemodynamic disturbances or who is having some issues of diabetes insulin, there is these kind of hormonal therapies required. But still many people still follow this, especially on a case-to-case basis. But what I want to know for all my understanding is that the regular supplementation of thyroxine has not been recommended of late, currently. Though some of the previous recommendations used to be there, based on the current evidence, there is no role of regular supplementation of thyroxine or thyroid hormone to these people. But though this is an arginine, vasopressin, hydrocortisone can happen, in many patients. Other routine measures are continued DVT prophylaxis, stressor prophylaxis, and PP selected the P protocol. And coming to the communication, because I don't want to drag the thing further, because you need to see that you choose the right moment. The family should be ready. The right moment, the right place has to be. There should be a room where people can listen to you. And you should talk to them in such a manner with a lot of empathy and sympathy in such a way that most of the time when the patient is, having a brain death, unexpected, especially with unexpected, unnatural circumstances, most of the time the family will be in a grief. The grief is likely to overcome their, rationality to donate the organ. So you should not allow the grief to, the emotions to overshadow their, the rationality to give the organ. That is what you should not allow that. So you should do it in a very clear manner, very concrete manner, right now with the appropriate sympathy, gel with appropriate sympathy and empathy is a must in that. And obviously, you need to have a support. You can have the counselors are there. Sometimes, even, for religious, clergy's help can be taken on an individual basis. And you have to explain the situation clearly. There cannot be any kind of ambiguity has to be there. There can be lot of doubts. Whether is it confirmed? Is there a 0.1%? Is there a 1 in 1 crore chances that it can be revived? Is there a point in taking the patient to another airlift patient to US or whatever, something like this kind of thing? You should patiently listen to the ear to explain the situation very clearly. And obviously, at least in India, we are not giving any kind of a pressure to donate any organ. It is voluntarily. It's because social contribution has to be very there. And answering all the questions are very patient. If you don't have time you are the wrong person to do that. And obviously, the impact of how the organ donation is going to be a social thing. It is going to be the only option for for the patient to survive and sustain their life. That's very, very important. And it's a social contribution. It is going to give life for multiple people. One organ for one person is going to help around 5 or 6 people at least, I believe, if I'm not mistaken. So these has to be called to the family. And obviously, at each and every time, you need to see that the emotions are not overshadowing their capacity to think and to decide. And obviously, whatever the family decide, you have to decide. That's also very important for this kind of communication. And you believe the cultural and religious issues. And obviously, they have a lot of doubts how the retrieval is done, how the things are going to happen. Many times in my practice, what I have seen is that people are in a hurry. Some people very, sometimes they think about organ donation. They want to do everything in a hurry, whatever, at the earliest possible within a few hours. But it may take at least around 24 hours, the best measures. Though with a lot of networking and contacting, it can be still reduced, but that is the reality. And about the discovery of organs, they have to see that it is going only through the proper channel. And another thing is that we will never be going for any kind of a diagnosis. I mean, the bone death, the brain death cannot be an impetus. There cannot be impetus for the diagnosis of brain death just because we want to transplant. We all know that. All the ethicality has to be, ethical and legal has to be 100%, it has to be followed and documented. And keep the family informed and provide the contact information, and we have to see that. And my take home is very simple. It's a general take home because I know it's a huge discussion happening here. There is a significant, like Dr. Sonal has mentioned, there's a significant mismatch between the demand versus supply of life-saving, life-sustaining organs across the globe. Obviously, the organ donation, organ transplant is the only option for people with end-stage organ failure. Donation of circulated to the cardiac is increasingly being considered and performed. Maybe in India, I think 1 or 2 are there, but I think maybe the transplant experts, maybe the better people to comment about that. Appropriate care of the diseased organ is important not only to prevent immediate, late post-transplant complication, but also improves the number of organs being retrieved. It's very clear. Clarity and transparency in the communication process, gel with sympathy and empathy, may help family to overcome the grief, overshadowing decision process in favor of organ donation. Because obviously, there's a lot of emotional elements are there. You should understand that you have to empathize and sympathize with them. It is difficult for them with your clarity, with a clear this one. Many times you may be successful, but obviously, finally, there is no pressure on anything. Education of the public with attempts and legislation will also help the process of organ donation. What I understand is that, at least in certain countries, if I know some Spain, some kind of a Scandinavian countries, even in Singapore, the organ donation is, after the death of the patient, the organ is, belong to the state, and the state has the, the power to, implant for the benefit of the social benefit. So maybe some kind of a legislation may help in the future, but obviously all the changes are always, slow. As you said, the society is going to change only slow. Once the alertness and awareness comes into society, these kind of legislation may be more successful. Thank you very much for your patient listening.
Thank you, Dr. Ajit, for that excellent overview of optimization of potential disease donors. And we'll take the questions towards the end. There are a few questions in the chat box, which I think you can go through. Meantime, we shall go to the next topic, which is on abdominal organ retrieval by Dr. Romal S. Dr. Romal is a senior consultant, HPV and transplant surgeon at Aster Hospitals, Bangalore. Over to you, Dr. Romal. Dr. Romal, you are muted.
Yeah, allowing me to unmute. Yeah, now it's come. Yeah, am I audible?
Yes, Dr. Romal. Yeah.
I hope my screen is being shared.
Yeah.
Thank you, Dr. Charles. Thank you, Dr. Sonal, for this opportunity. To LTI also. I just quickly take you through the process of abdominal organ retrieval, where in this talk, I will restrict myself only to liver and kidneys, small bowel, pancreas, and other things won't be included in this. Directly going towards the process of organ donation, retrieval, it could be in-house, it could be at a peripheral center, it could be at a remote center who otherwise don't perform transplants. So it's very important to go, and once you have the information, to check all the details that are available, which includes history, clinical status, how long the patient has been in hospital, have been in any downtimes, any resuscitations, the MLC status, and specifically organ-specific investigations like an LT for liver, the HbA1c, and other things for pancreas, and all the other lab parameters, including the markers. As a rule, uncontrolled sepsis and uncontrolled malignancy is a contraindication for transplant, but the other Hep C are relative contraindications, and age per se is not a bar for a liver donation. Depends on the assessment and the viability of the organ. Like I said, many times these are in peripheral centers, otherwise non-transplant centers, which are not equipped to deal with surgeries and transplants. So it's very important once we reach there to introduce yourself and your team to the donor hospital. Always check the essential paperwork, which includes the consent, which I'll just show you the Form 10 and Form 4. And also check the confirmation of the brain certification, involves 2 committees and all the signatures there. Confirm the blood group, confirm the identity of the patients, the virology, blood test, and the MLC status and the police clearance also. So this is the Form 10, which is for the certification of brain death. And like Dr. Sol was mentioning before, the Form 8, we want to specifically see what all organs and tissues have been consented for retrieval. It's very important to have communication with all the teams involved, because there are multiple teams involved. There could be a thoracic team, lung team, heart team, abdominal team, other teams. So it's very important to have a communication with everybody in the OT, including the anesthetist, the other teams, the OT staff. Donor family wishes are paramount, and many times they have timelines during which we have to respect and adhere to. And similarly, the OT time, because there could be specific requests from receiving centers as to when the organs have to be transported. So sometimes we have to time ourselves according to when the organ has to be transported, so that we do due justice to all the organ transplant teams involved, and try and utilize as many organs as possible. So as in any surgical procedure, complete asepsis is essential, and a complete scrub is done, like as in any proper surgical procedure, and the draping is done right from the chin down to the pelvis. So to give you a gist of this operation, I will just show you a few videos how this operation is, but a gist of this operation is to achieve a control of the aorta just below the diaphragm, and achieve the control of the aorta just the iliac bifurcation, so that we isolate a segment there, and then the perfusate is then instilled into this thing. So the aim of the operation is this one, so that we can then put in a perfusate fluid into this and perfuse the organs. So the incision extends from the xiphisternum, from the sternal notch down to the pubic symphysis, giving complete exposure of the thoracic and of the abdominal cavity. Many times, like I said, we don't have complete information on the donors that we have. It could be an older 80-year-old donor, 70-year-old donor whom we don't know. So sometimes there could be an undiagnosed malignancy which could be there. So after a abdominal exploration, abdominal opening, a thorough exploration is done to look for any missed malignancies which could be there, which could then contradict the donation. So complete laparotomy examination of the large bowel, small bowel, and pelvic organs, especially in females, has to be done. Also look for the liver for any nodules and other things, and only then we proceed forwards. So like I said, the incision begins in the midline. First, the abdominal cavity is opened with a midline incision, which we hold. Then the abdominal cavity is entered into, the liver is visualized, and a complete laparotomy, like I said, is performed to rule out so that we don't have any the malignancies. Next, we can proceed with opening the chest wall. This step can be done at a later step also, but if the donor is stable, it can proceed with that. And the chest is again open. Many times there is no chest electric saw, so many times we have to end up using a giggly wire to open the chest wall. Once the chest wall is opened, the sternum is opened, hemostasis is maintained, is controlled there, and a chest retractor is applied to give adequate retraction of the chest and of the abdomen. The next step is starts with a cattle brush maneuver, which is essentially lifting up the right colon from the retroperitoneum. So a self-retaining retractor can be used to retract the lower abdominal wall, and the step starts with lifting up the right colon of the retroperitoneum. This is because the major blood vessels are in the retroperitoneum, and the entire large ball, the right colon and the duodenum needs to be cauterized. So it's like a cattle brush with an extended thing. So this, as you can see, normally only a midline may be sufficient, but in some patients, when the patients are obese, you need to put a lateral extension so as to improve the exposure into the abdominal cavity. This case required that, that's why I had to proceed with that. Now you can see the exposure is better, and the right colon is being lifted up off the retroperitoneum, and this dissection is thus continued upwards to mobilize the entire right colon, and then visualize the duodenum also, and then the duodenum also has to be cauterized. So it's an extended cauterization which then proceeds, and once the IVC is visualized, we proceed more beyond the midline to visualize the left renal vein, which you can just see in this video a few seconds later. So that's the duodenum being cauterized and lifted off the retroperitoneum there. And that's the IVC, which is now visualized. And you can see that's the left renal vein, which is seen there. So that is the extent of our cauterization. Next step would be to identify, the aorta. Like I said, we need to have the aortic control just above the iliacs. So just lateral to the IVC is where the aorta is. We feel the pulsation where the aorta is. And then in the midline, dissection is started. Be careful to have a dissection above the iliac bifurcation because there are no important structures which cross at this level. The soft tissue overlying the aorta is slowly being divided. And like I said, the dissection is strictly in the midline. This is when the aorta starts to come into view and the aorta is dissected for a good length so that we have an adequate length for the aorta to be cannulated and cannulated. So that below there is the iliac bifurcation. We remain aware that this is the IMA is being ligated. We want to ligate the IMA because it gives us enough room and length of the aorta, which can then be safely ligated. The IMA is being ligated at this. Dissection generally doesn't proceed above much level of the IMA because then the renal arteries would be there. So this is looping the aorta. So we use 3 loops around the aorta. The first loop is now being applied, which is above the iliac bifurcation, like I mentioned. This loop will be later on tied. I'll show you in the next part of the video. Then 2 more loops are applied. This is to secure the aortic cannula, which there's a lumbar vessel there. These things, if they don't bother you, they can be left or they can be tied also. But if they're not in your way, they can be safely left behind also. So that is the number of ties that are put there. 1, 2, and 3 ties. I'll show you that, how we do that in the later part of the operation. So once this is done, pretty much the dissection inferiorly is over. And then we move to the mobilization of the liver, which starts usually with the division of the left triangular ligament. And at the same time, also it's important to have a look at the pars flaccida there, because this is the place where you can have an accessory left hepatic artery, which could, if present, has to be saved. Next comes to the dissection of the hepatoduodenal ligament. In this, we know the hepatoduodenal ligament has 3 important structures, which is the bile duct, the portal vein, and the hepatic artery. So the dissection starts first with the bile duct there. Before that, obviously, always palpate and look for any aberrant right hepatic artery, which could be arising from the SMA, which needs to be preserved. The bile duct is identified, looped about 1 centimeter, 0.5 centimeters above the head of the pancreas. And it is a good practice to always, aspirate it with the syringe and see and confirm that it's bile duct that you're dealing with. After that, the distal end is then ligated and the bile duct is divided. After the bile duct is divided, then the bile duct is flushed with cold saline, not under pressure, so that all the bile which is there is completely removed of the system. In addition to this, a cholecystectomy can also be done at this stage, or some centers prefer to do the cholecystectomy after implantation also. We generally complete the cholecystectomy at this stage. Once the bile duct is divided, then it's easier to identify the gastroduodenal artery, which is here. So the gastroduodenal artery is dissected there and looped and kept. This, we know gastroduodenal artery is one of the most important landmarks of the HDL, and it's pretty standard there. As an additional step, the common hepatic artery can be dissected and visualized, but this is not always necessary in a warm stage, because you should try and keep your dissection in the warm stage as minimal as possible, because chances of injury to vessels are high. So even if you visualize it and know it as a landmark, that is good enough. There is no need to actually visualize the portal vein at this stage, because that can be seen during the cold phase. So this is how it looks like. So that's the bile duct there. That's the common hepatic artery there. That's the GDA there. That's the right artery, left artery, and that's the right artery. In this, you can see we have already completed the cholecystectomy there. And that's the cystic duct stump, which is there. And behind that is the bile duct there. Next, like I said, once we complete the infra-aortic dissection and the hilar dissection, then liver can be mobilized off its diaphragmatic attachments. And the next important part of the surgery would be to achieve control of the infradiaphragmatic aorta. We know the aorta lies up there behind the right crest of the diaphragm. And it's important here where the left lobe is already mobilized, it's lifted up, and the Assistant retracts the esophagus laterally and the right crest of the diaphragm is visualized, and then this is divided to find access to the aorta there. I'll just show that in a bit. So this is what we aim to achieve, control of the aorta below the diaphragm. So that you can see the operating surgeon is lifted the left lobe of the liver up and has scored out the region of the peritoneum over the crus. The assistant has to retract the esophagus. The crus is then being lifted and divided, and the esophagus has to be, the aorta has to be identified at this level. Once it's identified at this level, this has to be looped up. Sometimes looping becomes difficult, especially in older patients with atherosclerotic disease. So it's not always necessary, but we usually follow, we use a Rummel's clamp there. So there you can see that that's the abdominal, that's the diaphragm, that's the aorta, which has been completely looped and filled up with umbilical tape. And we generally use a snugger to use as a cross clamp. Alternatively, a clamp can also be applied at this level. So once this is done, we know we have control below and above, and that's the snugger which we use to make a thing. So next important step, like I said, is then once this is done, we need to do a systemic heparization where we inform the anesthetist, where we give about 25 to 30,000 units of heparin. And after about 3 to 5 minutes of heparin is given, then proceeds the stage of the aortic cannulation. This step is important because now we're going to, once the cannulation is complete, we're going to cut off the cardiac blood supply and going to perfuse it through the infrarenal aorta. So the 3 loops that I was talking to about, these are the 3 loops there. This is a very important and well-coordinated step which has to be done by the first surgeon and the operating surgeon and his first assistants. As you can see, there is a second assistant who's come here, and the 2 hands of the second assistants are free, and their only work is to retract the ball and keep it away. The hands of the first and the second surgeon are free so that they can tie. The first surgeon the operating surgeon ties off the iliac just above the bifurcation so that the lower limb blood supply is completely cut off from there. Once this is tied, the next step is the operating surgeon has to cannulate the aorta. So this step has to be well coordinated between the first surgeon, the operating surgeon, and the first assistant. Like you can see, the operating surgeon is now holding up the aorta, pinching it upwards. There is enough room below the tie and the lower tie to make a nick into the aorta, into which the cannula would then be passed. The first assistant has held the tie up, and his only work is to ensure he ties down the tie to ensure the cannula snugly sits into the aorta. So that you can see now the aorta has been created. And the first assistant is tying the tie to ensure that the aortic cannula sits there, because we know this is a high pressure system. So this can just suddenly jet out and we could lose blood within seconds. So this is a very well coordinated step which has to be. After one tie, there's an additional second tie which is also tied down to ensure that the aortic cannula sits in place. Once it's done, we use the additional lower tie to right along the cannula to make an additional thing so that the cannula doesn't slip forward. This cannula, which is coming from, we bring it below the freetending retract so that there is no movement around there, and the nursing staff should be instructed that there is no undue movement or displacement of the aortic cannula there. Once that is done, we are pretty much ready for a cross clamp. Before that, the pericardium has to be opened because we need to vent out in the cavity. So once the pericardium is open, you can see the IVC there. Once the IVC is seen and then it is cross-clamped, then the venting is done, and this is how the venting is done. And you can see the gush of blood, and the perfusion fluid has to start. At the same time, a lot of slush and ice is used for topical cooling of the organs, and the perfusion of the organ has now started. Perfusion solution could be UW or STK depending on center and depending on the size of the patient, till much the effluent is as clear as possible. So like I said, the MAME is isolate a segment of the aorta, and during perfusion, always make sure that there are no kinks and no blocks anywhere. Sometimes it happens that the lock of the cannula is not open, that the perfusion doesn't go well. So make sure the perfusion goes well, because now the blood supply is stopped and the organs entirely rely on this it to perfuse the organs. Make sure the outflow okay. The letting out in the cava is a nice and big one. You have 2 big suctions there. Additionally, you can open the pleura also if the lung is not in place, so that the fluid doesn't seep into the abdominal cavity. Always anticipate problems and plan so as to avoid these problems. So the steps are, after clamping of thoracic aorta and the abdominal aorta is done at the same time, the venting is started and then the abdominal perfusion starts. This is how a topical thing is done. It's preferred to use small pieces as slush. A lot of thing on the surface of the right lobe, left lobe, below the liver, on both the kidneys and the organs which are going to be retrieved. Next phase, once the perfusion is complete and the effluent is clear, starts the cold phase of the dissection. In this cold phase, because there is no warm blood going through the system. And this essentially, the aim of it is to retrieve the organs with as long length vessels as possible so that they can be safely implanted in the recipient. So either you can start, teams have different ways of starting it. Either you can start with dissection of the cava first or the hepatic artery first. So our aim, like I said, if there's any aberrant anatomy, that is try and preserve as long as possible. If there's an accessory left, try and preserve it with the left gastric. If there's an accessory right, which it will be dealt in the top, try and preserve as much length as possible. The splenic artery is isolated and divided, and the hepatic artery dissection is continued down into the aorta down below, so they achieve a patch of the celiac artery. The portal vein is divided. Again, depending whether the pancreas is retrieved or no. If the pancreas is not being retrieved, we can go down into the confluence and divide there, or else it's just divided just at the level of duodenum there, so that there's enough length for the pancreas team also. Once this is done, then liver attachments to the IVC and the diaphragm are then divided, and then the liver can be kept into the ice basin and perfused with solution. Next comes kidney mobilization, kidney retrieval. Kidney retrieval can either be done en bloc or separately, in which the incision is made separately into the IVC and the aorta, and make sure that you have adequate cuff of the renal artery. Once you divide along the midline, there's least possible of injury to any other vessels. And even if there is an accessory renal vessels, they can be safely preserved along with the cuff of the aorta, so that implantation of that can be easier. As a rule, especially if there's pancreas, the iliacs also have to be retrieved, but we retrieve iliac because sometimes we end up needing it in like problems also. So try and retrieve iliac safely without damaging the intima of these vessels. After which, all the cavity, entire abdominal cavity, thoracic cavity has to be inspected and dried, whatever ice and water is left behind, because there should be no seepage. Skin can be closed, need not close the parietal wall. The skin is closed in the knees in continuous fashion, either with a baseball kind of a stitch, so as to prevent any sort of leakage, because the body has to then be inhabited to have the need dressings are then applied. So to summarize, a safe organ recovery is very important to have good transplantation outcomes, and ultimately it is a combination of cooperation between several medical teams with different expertise levels. So a communication, cooperation is very important among all the teams involved. Thank you.
Thank you, Dr. Romal, for that excellent talk. And again, I think we'll go to the next talk, and we'll take the questions in the end. So for the next talk, may I invite Dr. Kishore GSP, who is a senior consultant in HPV and liver transplantation at Aster Hospitals, Bangalore, and Aster Fortis, Bangalore. Over to you, Dr. Kishore.
Good evening, everybody. Thanks, Dr. Sonal, and thanks, Dr. Charles and LTSI organizing team for this opportunity. I'll just share my screen. Is it visible?
Yes, Dr. Kishore, yeah.
Thank you. Yeah, so in a deceased donor transplantation, normally we have to bench the organ before it is ready for retrieval. before it's ready for implantation. The whole purpose is, to put it very simply, there should be no holes from the cava after you implant. So we have to make sure that the benching patches up the graft and it functions well on the recipient side. And one should have a single artery, preferably to reconstruct during the implantation. So the benching is usually done by the retrieving surgeon, and it is important to communicate whatever anatomy was there in the donor to the recipient surgeon who's going to implant. Another basic principle is to keep the organ under the preservation solution as much as possible, because during benching it should not pop out of the chamber, so that the cold ischemia and cold chain is maintained well. Timing of the benching is also important. And normally what we do is we start benching about 30 to 45 minutes before the explant, because when the hilum is taken down on the recipient side, and when you have just the caudate and the hepatic veins to remove, so at that point, if you do the benching, when the benching is complete, then the organ is out and the IVC can also be prepared. The IVC can also be prepared for the implant. So that will be a good way to time the benching, so that you may not really want to do a shunt all the time. You can time it comfortably. So general equipment needed is you should have the perfusion fluid, whatever you use, just as a standby, and a cannula if you want to perfuse it on the bench. Normally, use of loops is good because you can do it under magnification and with more precision. A fine pair of scissors is important to dissect out the extraneous tissue from the vascular structures. Vascular forceps and mosquito forceps are useful. Mosquito forceps actually will splay out the structures which you want to work on. Fine sutures and ties. A Watson chain is actually quite useful. You can use it as a probe to see if there are any holes in the cava before you close them. Infant feeding tubes are useful to align vascular structures, especially if you want to, say, anastomose an artery on the bench. It will make sure that there's no torsion. And a syringe, asepto syringe, can actually inflate the cava and make sure there are no holes before you close the bottom end. So broadly, bench surgery can be divided into three parts: preparing the IVC, preparing the portal vein, and preparing the artery. So when you look at the IVC, so what you can do is you have to start working on the vessel. So the mosquitoes are placed on the corner. So this is one corner, and this is the other corner where there are two mosquitoes. So this is just diaphragmatic tissue, which is on the side of the IVC, which is being divided. One simple rule is you can bisect it on the surface of the IVC, so that you can work between the IVC and the tissue. So as we know, this is the adrenal. So this is the caudal side. So adrenal, normally during retrieval, we don't try to dissect it like a living donor transplant. So we just remove tissues en masse most of the time. So the adrenal is separated, and there's an adrenal vein which has to be ligated properly. Because if this is not ligated, or if this is missed, obviously this will bleed a lot after reperfusion, and it will be in the back, so it will be messy. So it is important always to seek out the adrenal vein. Even if the full adrenal is not there, you should seek out the adrenal vein and ligate and divide it. So once that is done, the rest of the tissues around the cava are carefully divided. So it's important always to be oriented and be sure of what you're doing. Here in this particular case, this is the IVC. We can see it's from here to here. And there is a bridge of tissue here. So it's actually a caudate bridge. Sometimes it can be vascularized. Sometimes it can have a lot of parenchyma. So most of the times we all use a piggyback implantation. So we have to clear the posterior surface of the cava for implantation if you do a side-to-side cava-cavostomy. So this tissue is being divided. So that is the bridge of caudate, which is being divided so that the cava, the dorsal surface of the cava, is exposed properly. So after that is done, it's again important to make sure that we have a good length of cava that is free, for anastomosis. So the caudate has, sometimes there are branches from the IVC to the caudate here. So those have to be divided carefully. And at this stage, we should not make holes in the cava so that the caudate is separate and there is enough place for implantation. Once that is done, this is the ventral part of the IVC. This is the cranial end and this is the ventral part. So the diaphragmatic attachments have to be separated from there. Usually, as a rule, we can always dissect just between the vessel and the tissues, and you can bisect the tissues so that it falls apart on either side, and you can take it out separately. So once this part is done, once the cava is nicely free, again, like we checked for the adrenal vein down here, in the cranial end, we should look for phrenic veins. So this is just diaphragmatic tissue which is being separated from the IVC. So again, the important thing is you have to cut in the right plane. You should be aware of where the IVC is and where the diaphragm is and where the extra tissue is. So it has to be just cut in between the two so that there's no injury or holes in the cava. And it will just take up time if you make extra holes. So once the IVC is clean, you can use a probe. Here, like I said, you can use a Watson chain, or here the right angle is being used just to see and probe to see if there is a hole. So this is the phrenic vein branch. You can identify it sometimes during the dissection. Sometimes you will not find the vein. So you should actively seek it out. There may be more than one phrenic vein. So you have to carefully see it and then close the phrenic vein. So once this part is done, so you've completed dissection of the cava, it is clean. So depending on how you implant, if you're planning a caval replacement, you will leave both ends open. If you're planning a side-to-side piggyback like we normally do, what you have to do is you have to close the lower end of the cava. You can either close it with a nice running monofilament suture, or you can just double ligate it and leave the upper end and then close the upper end. So once both ends are closed, you can make a cavotomy in the middle, and then the graft will be ready from the caval preparation point of view. It is also important when you close the upper end of the cava, you should make sure that the openings of the hepatic veins are not compromised. Most of the time, it will be okay, but you have to be very careful. Sometimes if it's a short cava for whatever reason, if the heart is being implanted, if you're seeing the openings of the hepatic veins there, you have to make sure that those are not compromised. If that is compromised, then the outflow of the liver will suffer. So that is a small point to remember. So just to recap that, normally you can put mosquitoes in the four corners of the cava, or you can place a long forceps inside so that you are oriented to the way the cava is, and you can dissect the tissues away from the cava without injuring the IVC. It is important not to thin out the wall too much because otherwise it will lead to holes and bleeding. The diaphragmatic tissue can be removed, and we have to work just outside the liver capsule, because if the liver capsule is injured, again, it will bleed after reperfusion. Special note should be taken care of, and the phrenic veins and the adrenal veins should be sought out and closed. Caudate should be separated, and space should be made for the anastomosis. And top and bottom cava can be closed, and the cavotomy can be made depending on what your preference is for implantation. So this is how a completed cava looks. I'll show some pictures as well. So this is the adrenal vein. So we have to close that separately. Here the bottom cava has been closed, and this is what I was talking about. The caudate is sort of covering the middle of the cava. So it has to be separated, and there may be some caudate veins here which have to be ligated. If you see, this is the asepto syringe that is being used to inflate the cava. One end is closed, so if you inflate, the cava is going to balloon up like that. And if there are holes, you can check for holes on the dorsal surface and on the ventral surface of the lower end and in the upper end, so that you don't miss any holes. So once that is done, this is the top end of the cava. When you close the top end, you have to be careful that these holes are not narrowed. So that's also important. And this is the cavotomy. So it's important when we do the cavotomy that it is more towards the upper end. It's almost up to the suture line which we have closed, so that the outflow veins are draining nicely into the recipient cava. So these are some small things that we have to pay attention to. So once the IVC is done, we prepare the portal vein. Portal vein preparation is quite straightforward. Usually in DDLT, we get a long portal vein, and especially if the pancreas is not taken, we have the liberty of going all the way down, and we normally get it with the junction of the splenic vein and the superior mesenteric vein. So that's the bile duct, and this is the artery on this side. So an important point in the dissection is you have to sort of know where the bifurcation of the portal vein is. So you have to gently clean out the tissues on the anterior aspect of the portal vein. Make sure the bifurcation is seen, because when you're implanting, if you know where the bifurcation is, the chances of it twisting are quite less. So you'll know how the portal vein is oriented, and there will be no torsion of the portoportal anastomosis. Also, you can keep this, this when you put the graft in the field, the splenic vein stump will be on the left side. So that will also help you in orienting the portal vein. So once this is done on one aspect, the ventral aspect, you can actually flip the portal vein, and you can see on the posterior aspect and make sure that the portal vein is exposed all the way there. So that's the caudate, and that's the portal vein which is exposed. You can check for holes in the portal vein also by inflating it. The chances of having portal vein holes are less, but it's important to check, especially the posterior aspect. So that's the essentials of portal vein benching. So what is, so this is a completed bench in another patient. So you can see that the portal vein is completely clean. You have the bile duct here, and you have the artery, which is completely devoid of all extraneous tissues. And so this liver and all the diaphragmatic attachments have been removed, and the cave also has been closed. And so the graft is ready for implantation. If you look at the artery, again, it's important when you dissect over the artery, it's important to dissect on the surface of the artery. Use a sharp scissors. The scissors quality should be good, otherwise it will be a struggle. So you have to orient it in such a way that it is turned towards you, and you have identified the celiac artery patch, you have the splenic artery, you have the GDA. Once that is there, and you work on the artery towards the hilum. So you will know that if you're working on the common hepatic artery, you will know where the right and left are. You don't have to expose the bifurcation of the right and left, but you just have to slowly remove the extraneous tissue on the artery so that it is clean. Eventually, on the recipient side, you will end up, dividing the most these extra stumps, but it's always good to clean them and keep them ready and use them as required once the portal vein on the recipient is done. Then you can trim the artery and just do the anastomosis. So this is another video, very short clip. So again, what I was saying is you have to first orient the liver towards yourself. That's the portal vein being inflated, making sure there are no holes. So this is the patch. You can see that's the celiac patch. And a small probe is being used. And you can just inflate it gently. So you can see this is the artery going to the right liver. This is the right side. This is the caudate. This is the left side. So you can see that this is the left gastric artery. There are some branches along the lesser curve of the stomach which have been divided. So these are branches to the lesser curve of the stomach, branches of the left gastric artery. And you can see there's an artery here which is actually going inside the liver. So it's essentially a replaced left artery. So you have to be, when you do this has to be identified, obviously, when you do the donor retrieval. So it has to be identified. And if this anatomy is found, you have to preserve the left gastric artery so that you can see it on the bench and close the holes, and you can use a single stump of anastomosis. So it's always good to do whatever arterial anastomosis you want so that the implantation in the recipient becomes quite simple. So you can just implant a single artery. So as you can see now, the holes are closed, and then there is a single celiac patch, and it's filling nicely, and the left hepatic artery replaced is also preserved well. Yeah. So that's the left hepatic artery. So this is what I was saying. It is very important to be oriented. There's a lot of stumps that are hanging. You just have to orient it well and dissect carefully gentle traction, gentle handling. And it's not unusual to find replaced arteries, especially a right replaced is quite common. So this is a case which was like that. So this is a superior mesenteric artery stump. This is the celiac artery stump. And you can see that there's a replaced artery from the SMA going into the right side. And this is the splenic, and the left is coming off the celiac. So what we can do is we can anastomose the right hepatic artery stump. If you have, it depends on the size. Normally the right hepatic artery will go well with the GDA. So you can just anastomose the right hepatic artery through the GDA. Or if there's a cuff of SMA, it will be a good size match for the splenic artery. So that can be done on the bench, and then you can do a single anastomosis with the celiac patch. I'll just show a diagrammatic representation of this. So normally you have the common hepatic GDA and then right and left coming off it. Sometimes you have the replaced right from the superior mesenteric artery, and you have a segment 4 artery which can come separately and segment 2-3 which comes separately from the left gastric. So in this case, what you can do is you can just anastomose the replaced right to the GDA, which is coming off the segment 4 artery. And the segment 2-3 artery, like we saw in the previous case, you have to take it with the left gastric. There's a common celiac patch. Normally, you can put the celiac patch to the recipient. In this particular case, which we did, this is diagrammatic, but this was very atherosclerotic, and the needle was even not going through. So we used the splenic artery and anastomosed it to the CHA. So that's about it. So yeah, so thank you very much.
Thank you, Dr. Kishore. And because of want of time, let's go straight to the cases. And we have Dr. Raman, who is a senior consultant in HPV and transplant at Aster Bangalore Hospital. And he'll be presenting the first case and discussing the first case. Over to you, Dr. Raman. You're muted, Dr. Raman. Sorry. Can you unmute yourself?
Yeah, let me just share the screen. Is everybody able to see the screen?
Yes. Yeah.
Okay. Thank you. Thank you, Dr. Charles, and thank you to the organizing committee. And so my topic for today is to talk about unstable donor and to talk about rapid recovery and some of the steps and precautions that we can take in this kind of a scenario. Introduce myself. My name is Dr. Giran. I'm one of the surgeons with Aster Integrated Liver Care team in their Bangalore cluster. So essentially, I'm going to be talking about unstable donors with DBD category. That is more pertaining to our circumstances because we do not have or we do not have DCD retrievals here. So essentially, when we are talking about an unstable donor in a DBD category, we are essentially referring to an unstable circulatory status. So this is basically what I'm going to be talking about. So some of the conditions could be a peri-arrest condition or arrest during transportation to theater. It could be rapidly peaking inotropic requirements and tachycardias and tachyarrhythmias in the ICU. It could be a case where there is a documented retroperitoneal or intraperitoneal hematoma secondary to an RTA, or it could be an iatrogenic intraoperative bleeding. It could be the donors who have had previous laparotomy or major laparoscopic procedures where there are a lot of adhesions and advertent injuries can happen during the course of retrieval, or more and more, or sometimes where I have encountered that people with vascular stents in, and sometimes that history is missing. And also patients who have had thoracotomies before, where we can run into trouble when we are opening up the chest, or even severe chest infections in the past. So the goal remains the same. Goal is to minimize ischemic time, maximize number of organs that can be utilized from that retrieval, and obviously all this to maximize the transplant success. And then there is a very significant role of the logistics and team coordination, the surgical team, the perfusionists, the transport, and the retrieving center teams. And I'll briefly touch on the role of NRP, which is not there in our setup, or at least in not all the centers, but it does have a big role to play. Some of the inferences that I've taken from physiology are from the DCD data abroad, from abroad, and I think it is applicable to unstable donors as well. So a simple scenario, these are some of the personally encountered cases that I've had. 35-year-old male, brain dead after traumatic brain injury and a pneumothorax. He was on a relatively stiff dose of inotropes in ICU, but maintaining a MAP of 80. So this was in a peripheral hospital, and he was shifted to OT with the technician and a resident. There was not senior team around that much. So the patient arrested in the lift and the CPR started. We got the call in theater, and then the patient is getting wheeled into the theater. So this could be one of the situations where suddenly all the dynamics change. Some of the other cases that I've encountered are lung laceration with profuse bleeding, and this was basically a previous infection and a bit of lack of communication with the new anesthetist, because when you're in peripheral centers, you're always talking to newer teams, and you're working with newer teams who you have not met or worked with before. And obviously, once you open up the chest or in unstable donors, tachyarrhythmias, compromising the circulation can happen intra-op as well, where the strategies need to be changed. So what's the best way to prepare? I don't think there's any particular way to prepare. I think we are lucky that we have had a lot of DCT experience when we were working or training abroad. But some of the newer colleagues, answer here is that for all your days prepare and meet them ever alike. And when you're an annual bear, and sometimes you have to bear, and when you're in hammer strike. So when these kind of situations happen, you have to remember this word by Markham, and then do the needful, and all your skills that you have incorporated in life till that point come to the showmanship at that time. So some of the timelines for organ preservation, as I said, the goal is to maximize and to minimize ischemic time. So one thing that we should keep in mind is duration of instability and the time that we are planning the organ retrieval. This situation might be there in cases where there is instability documented already when the patient is in ICU and it is not an intraoperative event. So for example, if the systolics are going less than 100, and the maps are falling below 50, you should start considering it as an agonal phase, as we say. So patient might still be awaiting consent, maybe awaiting clearances, organ placement might still be happening. And, obviously the transport to the theater or to the retrieving center might still be in the process. So these things have to be expedited. We will not be able to place all the organs, but save what we can. And these are some of the things that we have to start thinking if we have window to see that. Again, in the case like we talked about, the patient arrested in the lift, so that starts counting as the agonal or the asystolic time. So now you have to start thinking about your incision time, and obviously you have to start thinking in terms of when you would be able to cross clamp and cold flush, and the hepatectomy time in these kind of cases has a very significant role, and there is a lot of data that hepatectomies that are taking more than 60 minutes definitely have a significant impact on the quality of the livers that we use. So again, as I said, your whole strategy now and your technical skill and your communication skill all come in handy. And idea is to minimize the warm ischemia time and again, get the organ cold, and then start communicating to the receiving center so that you can minimize the cold ischemic time as well. So some of the dreading outcomes, why are we worried about an unstable donor? So what we call a toxic liver, obviously this could be a primary non-function eventually as well, but some of these livers, if they're not retrieved properly, they can lead to some hair-raising reperfusion syndromes when we see them in data. And eventually, if the organs don't pick up, then they lead to a cardiac insult, they lead to renal insult, and as a result, the ICU team and the ICU care becomes really complicated. And there can be adverse outcome just from these events or the quality of grafts. And obviously, some of them can end up with primary non-function. Ischemic cholangiopathy is another dreaded complication when there has been prolonged ischemias, which compromise the intermediate and long-term results of any graft. So this is a good sort of picture or study that is from the US data in the Transplantation Journal. And what they've realized that the shorter the agonal phase, as you can see in this picture, actually the outcomes are better. So if you have a lingering periods in the ICU where we are having low systolic pressures, low tachyarrhythmias, we should not keep waiting sometimes to stabilize the patient. If the things are in order, we should proceed to an early retrieval and done in a timely fashion, because that would eventually lead to better outcomes in both intermediate and long-term results. So organ assessment and decision making. So that's a very important role that a retrieving surgeon plays in these kind of situations, because what are the decisions that you may need to take? Should you proceed to a super rapid recovery? You have to start communicating the transport logistics. And it all depends on the experience of the team around you, your experience, and the hospital logistics of the recipient center where you're going to be sending this kind of an organ. When the patient is unstable in ICU, obviously we have modalities such as LFTs, lactates to monitor imaging, biopsy, or an ICU. But in case this kind of instability happens in theater, or just before the patient is getting shifted, as the case that we talked about, then you resort to some very basic things from experience, which is the feel of the organ, whether it is stiff, the shape of the organ, and these are the kind of things they add a lot of value. And again, the key strategy remains to minimize ischemia, proceed to super rapid recovery techniques if needed, rapid cold perfusion, and normothermic perfusion techniques and the facilities if they are available to you. So what is super rapid retrieval that we talk about? This is the standard retrieval practice as it used to be before NRP machines came into picture, particularly if you look at the time period in UK or abroad from, the whole of the decade from 2000 to about 2013-14, when NRP was not a standard practice. So super rapid retrievals of liver ideally had to be done within about 30 minutes window. So you straight away proceed with a midline laparotomy. You don't try and open up the chest initially. It's totally dissection and cutting done with a sharp knife rather than any scissors and things like or diathermy. So peritoneal entry with directed focus on aortic cannulation. Ideally, you should be able to accomplish this within 5 to 8 minutes. So you need team readiness, you need staff, you need extra pair of hands. You don't have time for putting too many of retractors in there. You need assistance to get the organs out of your way while you're reaching straight for the aorta. And you need a good assistant, because here you have control of the aorta in your hands. What Dr. Rommel had shown before, you may have to hold it, you may have to put a clamp below on the aorta and be able to put a tie or whichever system, and then be able to cannulate with the adequate gauge cannula. And you are actually handling it, and your assistant is actually tying, so it actually helps if there's a good assistant with you. Aortic cross clamping is the next step. You use scissors to get rid of the right diaphragmatic crest. You proceed to immediate venting, which is usually intra-abdominal, and you start, wait for about 30 seconds or so, and you start the perfusion. The first can be a normal saline, let it vent, and then you can get your clamps and your sutures and things in place once the venting has been done. So it is perfusion first, dissection later technique. When the perfusion is running, ideally after about 2 to 3 bags of UW have run with heparin in them, you start your hepatic artery bile duct dissection. Usually we perform a cholecystostomy rather than a cholecystectomy to let the bile out, and you can also flush the gallbladder directly in there. So this again step takes literally about maybe about 10 minutes, 10 to 12 minutes. In situ portal perfusion is helpful if you're able to accomplish that. And once you have dissected the bile duct and once you have dissected the hepatic artery, you can directly make a nick in the portal vein, hold it, put a portal cannula in there, and at least run a letter of UW without pressure. So this is totally focused organ harvesting. There is no unnecessary dissection. And then there is a rapid removal, and straightway the organ is cooled and packed, ready for transport. And this whole process usually, again, should take about 10 to 12 minutes. So that's how you add up to about 30 minutes. 30 minutes, obviously, an average, but usually you should be able to accomplish this within about 40 minutes. So this is the super rapid retrieval technique. If the patient, for example, you don't have to always resort to it unless there is an arrest or something in theater, but if you feel that the patient has been unstable in ICU and is unstable on the way down and the systolics are fluctuating, then it is better to go straight for aortic cannulation and go for perfusion, slightly in a controlled fashion, may not be in a super rapid retrieval of liver way. So some of the guidelines, your duty doesn't finish there. So this is just one part of the retrieval you have done. Then this events and the state of the organ have to be communicated to the receiving center. Ideally, if there's a senior surgeon retrieving, he would have told the quality of the organ and the recipient center would have started the hepatectomy because you want to cut down on the cold ischemic time. And appropriate packing in the ice box, all those measures are important, and the organ has to be rushed over to the recipient center. Again, your anesthetic team should be aware of that. They should be prepared for a stormy reperfusion. The anapatic phase should be kept brief. There should be a rapid recipient hepatectomy that is done in these sort of settings and not prolonged procedures. And the idea is to get the blood flowing again. One step about these kind of retrievals is that usually go below the level of the GDA. Always assume there is an aberrant anatomy then rather than find it. Always assume there is a replaced right. Always assume there is a replaced left gastric. So your field of dissection should be along the border of the stomach and the gastrohepatic omentum area and should always be below the level of the GDA. So some of the things, this is interesting LTSI guidelines on DCD, which I think are applicable to unstable donors. And so donor hepatectomy time, there is a clear evidence now that hepatectomy is more than 60 minutes, irrespective of NRP, have an impact on the long-term, outcomes or even increase the rate of PNFs. So this is the ILTS guideline that, the hepatectomy should always be kept under 60 minutes, ideally 30 minutes. So dual cannulation versus single cannulation, when you're in a rush, whether we should just cannulate the aorta alone, dual cannulation with portal perfusion definitely has benefit. And it is easy to perform once you have dissected the bile duct and you have dissected the hepatic artery. It is easy to make a nick and at least be able to perfuse a litter in situ rather than taking it out and doing it, because then it just helps you pack the liver quicker. Type of preservation fluid, STK in DCD at least has been shown to have inferior results, particularly if the cold ischemia is expected to be more than 8 hours. So UW might be the preferred fluid choice here. Use of fibrinolytics, some small studies definitely have shown benefit with that. And initially when we were in UK, we used that for about a year as well. But overall, the evidence is not in favor. And simple heparin in the first 2 bags of the perfusion fluid, 25 to 30 units of heparin in each of the bags is good enough when we are pushing the perfusion fluid through the aorta. So something about the future directions in this kind of a scenario. This is one of our experience use of NRP machines. I think we need to use more of these. We need to gain our experience more of these. You can use them for splits. You can use them for preservation. And I think centers have to work together to, make these things viable and make these things available. At the moment, there is a patchy availability in our settings. There's a lot of evidence now from the DCD livers, and if you look at the NHSBT data for the last decade, it's almost like a threefold increase in the use of the livers, particularly once they have been put on the NRP machine. A threefold increase is a lot. Again, there is improved organ utilization, and you can see there's a threefold for the liver. And 12-month, the liver transplant survival was superior to recipients with the DCDs that have been put on the NRP machine. So this is something definitely we should consider. Again, this is quite an elegant graph. Initially, the DCD started, when in 1980s late, actually. They didn't really pick up till about second half of 2005 onwards. But there was a learning curve associated with it, as you can see. And these are the DCD curves. And now it has almost matched, and probably the second line, probably 2010 onwards, is secondary to the NRP usage here. I think for us in Indian setup, we need to analyze and register our data from the registry better and see which side of the curve we are at. And I think that will give us a good picture over the long run about the activity we are doing in India. And particularly, we might be able to use more unstable grafts, not only DCDs. We need to work on increasing the organ donation rates and education and motivation, because sometimes patients are stable in ICUs and they become unstable just because of inadequate care in the ICUs, where we have to sort of resort to these measures rather than any other reason. Thank you. So idea is to start where you are, use what you have, and do what you can. And floor is open to questions.
Thank you, Dr. Gurn, for that excellent discussion. And we'll take the questions towards the end. So let's go to the next case, which will be presented by Dr. Vachan. Dr. Vachan is a senior consultant, HP and transplant surgeon at Aster Hospitals, Bangalore. Over to you, Dr. Vachan.
Hello?
Yeah, we can hear you, Doctor.
Yeah, hi. Thank you. Just a minute. So thank you, Dr. Charles, and thank you, Dr. Abhidip. I'll try to keep it short in view of the time constraint. So it's quite simple. As an organ procuring surgeon, when you go to get an organ, it's very simple. You're supposed to get a good graft and you're supposed to reject a bad graft. Most of the time, the problem happens is that the organ is actually lying somewhere in between, where you're not quite sure whether to accept it or not. Now, most of us will be happy to accept a graft from a young donor who's having a low BMI with minimal ICU stay, not on much inotropes, no sepsis, normal LFT functions. When we get the call for an organ donation, we usually get a form from our SOTO, which tells us the age of the patient, the relative details in the form of the LFT, in the form of BMI, cause of injury, relative hospital stay, etc. Now, coming to the scenario, suppose you are going to retrieve an organ, you know the details that it belongs to a middle-aged person who is slightly on the higher BMI, has a history of diabetes mellitus or a history of alcohol consumption, has mildly elevated enzymes, and an ultrasound showed a grade 1 fatty liver. What are you going to do? You look through the abdomen, you find everything is okay, then you come to the liver. You're supposed to assess the color, surface, consistency, and edges of the liver. The liver should be a healthy brown to pink. It should not be yellow. The more yellow the liver is, it means it has a higher fat content. If the liver is congested, it is going to have a purplish dark hue. Consistency should be soft to spongy. If it is hard and indurated, it may not be a good liver, and definitely it's granular or nodular. You don't want to use that. Edges should be sharp. Blunting of the edges usually signifies fat content. It usually progresses from the right lobe to the left lobe. If you get a liver like this, or a liver like this, which is healthy pink to brown with good edges, soft in consistency, you are going to accept the liver. If you get a frankly cirrhotic looking liver, you are obviously not going to use them. Now comes the problem. Suppose you get a liver like this, which though on gross appearance seems to be of a good color and sharp margins, but as you can see, it appears to be stiff. Just by retracting the rib cage, the liver has actually lifted up from the stomach. Then you get a liver like this sometimes, which is slightly granular, slightly fatty. You don't know what to do. If you do not have the facility of a biopsy with you, you can flush the organ and see how it flushes. If after flushing the organ is uniformly flushed, you accept it. But if it looks something like this with a patchy flush, you should not accept this organ. Sometimes you get old livers, even though they are soft to touch, they have sharp edges, they may have a granular appearance. Then you can have liver like these, which are frankly yellowish in color, and the more you pinch it, the more yellowness you see. Now, these last three cases are the ones where we will need to do a biopsy. Now, how the biopsy will help us is it will help us to tell the architecture of the liver, presence of either the fat or the fibrosis, presence of inflammation, presence of necrosis, etc. Fat content of the liver is classified as mild, moderate, severe. Less than 30 degrees, good, you can accept this organ. More than 60 degrees, should not use this organ. 30 to 60 is where the dilemma lies. Now, on the histology, you are going to see the image like this. The fat droplets can be in the form of large droplets, small droplets, or a mixed picture of large and small. You are supposed to calculate them together. In our case, the one which we are trying to discuss, since there was a history of presence of mild alcohol intake present, the liver biopsy was like this. There was presence of gross steatoinflammation. This liver was not accepted. Now, why biopsy is important? Because they have seen, one, they have characterized that depending upon the presence of fibrosis, inflammation, and steatosis, you characterize the liver as either low risk if there is no fibrosis, no inflammation, and mild steatosis, to something known as high risk where you have a higher degree of fibrosis, moderate inflammation, and macrosteatosis. Now, how accurate is an intraoperative assessment? Unfortunately, the correlation between the ultrasound findings, the surgeon's perspective on the liver, and the histology are sometimes known to vary by a lot. Sometimes we may end up rejecting a lot of livers which we could have actually used. This is the cases in which digital image guided analysis can help, because it was shown that surgeons routinely overestimated the extent of fat, and digital image analysis was found to be more accurate in estimating the fat content of the livers. Now, similarly, when it was noted that after the starting of the normothermic machine perfusions, a lot of the livers could have been viable. Like in this study, out of 185 livers, 31 were checked for viability, out of which 22 were actually found to be viable. They were used and they were found to have good outcomes. Artificial intelligence is definitely going to come up. It has already started. There are a lot of studies from the NHS, from Spain, as well as from US, where they have trained the AI models to actually, to train the AI models to study the fat content by looking at various images. And it was found to give a more accurate presentation of the amount of fat content. Now, what is the concept of an extended donor criteria? Now, the need for the organs in India is much more than what is available. So we do not want to waste organs that can potentially be used. So organs such as from donors more than 65 years, higher BMI, prolonged ICU stay, hypotension, previous cardiac arrest, presence of higher fat content, sodium fluctuations, higher enzymes, higher bilirubin, splitting of the graft, seropositive graft, patients who have had sepsis or history of extrahepatic malignancies. All these potential donors are clubbed together under as extended donors, extended criteria donors. Now, extended criteria donors over various studies have been shown to have a slightly higher incidence of complications, slightly higher but not statistically significant incidence of graft loss and mortality. Again, another study from China showed that there was no significant difference in bilirubin enzymes, complications, or survival on using marginal donors. Now, if you club together all the various extended criterias, there is not a major difference when it comes to the graft age, steatotic grafts, grafts from DCD donors, seropositive grafts, grafts which are used as splits, and graft that nobody wanted. That is, if one center has rejected it and the other center has used it, uniformly we see that there is a non-inferior outcome if we use these organs. That is, what we are using can potentially be increased by making use of these marginal grafts. So the onus is always on the procuring surgeon to decide whether they are going to take the organ after looking at it and assessing it. If there is any doubt, please consult your senior, take a biopsy, take multiple pictures and assess it. And if found suitable, you can accept the organ. If suppose you have decided you are going to go ahead with the organ, you have started the retrieval. Now the major aberrations that you can encounter, usually in the form of bile duct anomalies, is not very relevant in a case of a cadaveric donation, though it's highly relevant in case of living donation. Again, portal vein anomalies are far in between. Sometimes there can be an anteriorly lying portal vein, which is acceptable. But in case you get something like this, that is an EHPVO-like picture, if there is no single vein perfusing the liver, this graft may not be usable. There are innumerable described arterial anomalies, which include anomalies of both the right hepatic artery as well as the left hepatic artery. The left hepatic artery can be either replaced or accessory and can arise from either the left gastric, splenic, or directly from the celiac. Similarly, you have different variations for the right hepatic artery, which can be an accessory or a replaced. Now, this is an example of an image. The important thing to note is that after dividing the bile duct, sometimes you encounter an area along the right side of the portal vein, which is slightly thick. You have a lymph node, but you have nothing palpable here. Many a times the accessory right hepatic artery is quite small in caliber. You will not be able to palpate it. So if there is any doubt, keep this tissue and try to study it, or rather dissect it in the cold phase. This is just a short video showing presence of aberrant artery. So this is the presence of an replaced/accessory left, which was found to be arising from the left gastric artery. So the left gastric artery was completely dissected off the lesser curvature of the stomach to its origin in the celiac axis. This is the splenic artery. This is the common hepatic artery, the gastroduodenal, and the proper hepatic artery. So preserve all these so that you can study it on the table and bench if required. Now, sometimes when you have a completely replaced right hepatic artery, it is important to take the whole tissue along with the patch of the superior mesenteric artery. Like in this case, we have taken the superior mesenteric artery, which is giving off the accessory right. We have taken the celiac, the splenic, left gastric arising from the common hepatic/celiac, common hepatic, gastroduodenal artery. This is the aortic patch where you can see the opening of the celiac as well as the superior mesenteric artery. While doing the anastomosis, you can either use this part and this part separately to do two anastomosis, or you can use the gastroduodenal stump or the splenic stump to anastomose to the right artery so that you can do an anastomosis with a single artery. Sometimes you have lobar agenesis, which is a congenital anomaly. The liver per se is nice. This is quite scary to look at, but if you do a biopsy and the organ looks good, you can use this. Caval anomalies are well described, but it is of slightly less relevance because we always take suprahepatic IVC and infrahepatic IVC. Situs inversus has also been described, though rare. To conclude, it is always better to take more tissue than required if there is a doubt of any arterial or portal venous anomaly. Always keep your dissection just above the level of the duodenum so that you do not go above the level of the common hepatic, just in case you can injure any arteries. And always take enough length of the arteries, especially the left gastric, splenic, in case there is need for a reconstruction on the bench. Thank you.
Thank you, Dr. Vajan, and that was excellent discussion. Dr. Sonal, over to you for the final concluding remarks, and we can take any questions that are there in the chat box.
Okay, so I think that while
Can't see you, Dr. We can't see you.
participants, yeah, sure. Our participants actually have been speaking. We have been answering a lot of the questions on the chat box. I think that we have had a lot of discussions on DBD. Some of the questions that have coming up have been on DCD. So it's quite important. Perhaps that's something that we have not discussed in detail. There have been 2 or 3 notable developments in the last couple of years. One is that there is a guideline by the Supreme Court on withdrawal of life-sustaining therapy. As you may know, it was illegal in India before to actually withdraw life-sustaining therapy. And the Supreme Court actually set out a guideline which allowed us to do that. I'm just going to quickly show you something. Are you able to see my screen now?
Yeah.
So the Supreme Court judgment basically set up if you have or futility of treatment, this can be actually decided by a primary medical board, okay, which is actually obviously in the presence of the guardian and the relatives. They form an opinion within 48 hours. Then it goes to a secondary medical board, which is actually under the chief medical officer of the district and with different subject experts. This can give another opinion within 48 hours. This can then go for the consent of the guardian and the relative. Then after getting permission from a magistrate, because you can actually withdraw life-sustaining therapy. So obviously this is linked to organ donation in a particular way because you're able to perhaps think about DCD after this. So the questions that have been happening, one of the surprising things for us was that Karnataka was quite proactive in this, and they issued a circular to facilitate the right to die with dignity in January, which actually has replaced the secondary medical board with experts that are already certified to brainstem death testing. So they've made it much easier to do that. So time of death in DCD is the time when the heart stops. After the heart stops, there is a no-touch time, which is a 5-minute time with the agonal phase, as it's called, to ensure that the heart does not restart, after which organs can be procured. So organs are usually procured by rapid recovery. When cannulas are put inside the OR, the ideal time of cannula insertion is probably anywhere between 5 to 10 minutes, the sooner the better. Or you can actually institute normothermic regional perfusion, as Dr. Raman has already alluded to. So these two judgments are very intricately linked, the WST judgment and the DCD SOPs. So currently, Karnataka is actually in the process of formulating DCD SOPs for organ allocation. WLST has already been formulated, in India and in Karnataka. So, but that was an excellent discussion. Thank you so much to all my colleagues and for participating and clarifying the air. I hope that has been helpful for people. Now, the last question that I would like to answer is by Dr. Jyoti Kharel. No touch period. What is the following in India? It's about 5 minutes in India at this particular time. If there is any other questions, we can probably take them. Otherwise, we can probably wind up.
It's already 9 o'clock, and I think it's time to close. And thank you, Dr. Sonal, Dr. Vachan, Dr. Ajit, Dr. Kishore, Dr. Raman, and Dr. Romal for that excellent discussion. And maybe we'll take up DCD, normothermic regional perfusion, and machine perfusion as a separate masterclass because they are topics on their own. So thank you all, and thank you everyone who has joined today for the masterclass. And we invite you to the next masterclass in May, which will be on hepatocellular carcinoma. Thank you all, and good night.
Thank you for having us. Thank you.